Hello everyone, this is Pure Cognitions. My name is Anastasia Hunter, and our guest today is Dr. Judith Herman. Dr. Herman is a professor of psychiatry in Harvard Medical School and one of the most famous and important world experts on trauma. In this video, Dr. Herman will tell us about herself and her work, and will share recommendations for people experiencing trauma and psychologists working with it. Please subscribe to our channel, like and share this video if you consider it interesting, and I hope you enjoy it. Dr. Herman, welcome. Thank you very much for coming.
Thank you for having me.
Thank you. Could you please tell us a bit more about yourself? Just anything you consider important. How did trauma become the center of your work?
Well, I am. I grew up in New York City. My grandparents were Jewish refugees from the Pale of Settlement in Eastern Europe. They fled the pogroms and to get away from the Tsar's army, which was a death sentence for them. And they, it was kind of the immigrant story in the US. They worked in the garment factories, and then they got their kids got an education. And I left New York to come to Harvard as a student, and basically never left. But when I was starting my psychiatric residency in 1970, I had just joined what was called a consciousness raising group. This was the basic organizing tool of the women's liberation movement. They were small groups where we actually talked about our lives and sort of understood the condition of women by actually talking about all the things that weren't supposed to be talked about. And so when I began my residency, I had that awareness of the condition of women and how much violence women endured in secret. And my first two patients on the inpatient unit where I started my residency were women who had been hospitalized after making serious suicide attempts. And both of them gave me histories of father-daughter incest. Now, at the time, our basic psychiatry textbook estimated the prevalence of incest as 1 case per million population. If that were true, what do you think were the chances that a beginner would see 2 cases her first month on a psychiatric unit? So kind of everything grew out of that. A colleague and I wrote we started talking among ourselves, and we realized how many cases we were seeing, and we wrote a paper about it that was published in a women's studies journal. At that point, I don't think any psychiatric journal would have published it. But we, in no time at all, we collected 20 cases of incest. And so everything kind of grew from there.
Thank you very much, Dr. Herman. That's every time I hear the story, it's so inspiring. What you did in those times was just unbelievable at the moment.
Well, I think it was, the take-home lesson was that I didn't do it alone. It was part of a movement. We would never have had the courage to speak up about these things if we hadn't been part of a movement for women's rights.
It's a really important topic, and thank you very much for bringing it and speaking about it. Right now, it's still so relevant, especially
Oh, totally.
for us.
Yeah, no, it turns out now that we have the data, violence against women and children is the most common human rights violation in the world.
Thank you for telling us about it. And since then, were you just working with the incest trauma, or it just started to grow to trauma in general? Could you please tell us a bit about trauma and your work on it?
Well, yes, it grew from specifically talking about childhood trauma to trauma more generally. And in the 1980s, I began working at Cambridge Hospital, which was one of the Harvard teaching hospitals. And we got a small grant from the city of Cambridge to develop mental health services for crime victims. And so my colleague, Mary Harvey, a psychologist, and I began developing this service in the psychiatry department. And we did a survey among the clinicians in the department of how many people they were already seeing who had histories of childhood abuse or domestic violence or some other form of violence in their lives. And of course, it was a large number. We didn't see a lot of military trauma because in the US, the military has a separate set of hospitals for the soldiers and veterans. But we began to began to meet in a study group that was pulled together by my colleague Bessel van der Kolk, who was working in a military hospital and seeing combat veterans. And we were interested in looking at the common features of trauma, whether we were working with combat veterans or refugees. We did see quite a few refugees at Cambridge Hospital, or survivors of gender violence or hate crimes. So we, for several years, we met once a month in people's living rooms and just kind of took turns sharing our work. And really, and out of that, it became clear to me that whether you're talking about the political sphere of war and prisoners of war and political prisoners, or whether you're talking about the private sphere of family and sexual relations, trauma is trauma. So it was really on the basis of that I wrote Trauma and Recovery.
Mm-hmm. Yes, Dr. Herman, thank you. So now that you said that trauma is trauma, could you please tell for our listeners who are not psychologists, so what exactly is trauma? So is it just something very stressful that happened to me, or can it also be something that never happened to me, but I just feel like I was deprived of something very important in my past?
Well, we studied this we actually looked at, did people develop classic symptoms of post-traumatic stress disorder after stressful and unpleasant life events like being fired from a job or a divorce or simple bereavement? And the answer was no. Um, uh, when we say trauma, we mean up close exposure to threat of death or serious bodily harm, or witnessing that up close, like the way police and firefighters may, you know, see people killed in front of their eyes. Uh, uh, and so it involves both the experience of terror and helplessness. It's when you can't, you fight or flight is useless. You're helpless, and you think, oh my God, they're really going to kill me. This it's, or an auto accident, for example. It doesn't have to be interpersonal violence. It can be, a fire or a flood or an accident, but that is life-threatening. And the typical symptoms follow. There's a spectrum of disorders, from the acute stress disorder just in the immediate aftermath, where people, they're shaking and they can't, their hearts are racing, they can't calm down, that sort of thing, to post-traumatic stress disorder, which involves reliving the experience, having flashbacks and nightmares, still being hyper aroused, for, expecting danger every minute. And a typical symptom would be a startle response. You hear a car backfire, combat veterans who hear a car backfire and duck for cover because they think they've been, that someone's shooting at them. And then numbing. You either feel nothing or you feel too much. And people will say things like, I left my body, time slowed down. I thought, I was like it was like a movie, but it wasn't really happening. Those are dissociative symptoms that often happen spontaneously in the moment when one is helpless, and can recur in post-traumatic stress disorder.
Thank you. So, for example, if I had such experience as a child in my childhood, but now I'm an adult and I feel like I just moved on, grew up, and like it's not such a big deal. Yes, for example, I had interpersonal violence when I was a child, but now I feel that now I'm a bit worried that if I just go to therapy, that will just make me less focused on my current goals, or I'll just start ruminating about my past. So do you think it's necessary for everyone who has ever experienced such an event to go to therapy, or it's not necessary?
Oh, no. No, I mean, many people recover, without benefit of any kind of help. And we actually have good data that predicts that identifies the factors that will predict a good recovery. Because in fact, the truth is most people who have experienced trauma never get any therapy. There's an interesting study that was done by two women named Ann Burgess and Linda Holmstrom. They were on call for a year at a Boston City hospital, and they saw every rape victim that came into the emergency room. And then they followed up with them 4 years later to see how they were doing. And most of them had not gotten any treatment. the ones who did, but quite a few had recovered pretty well. The ones who did well were people who took some sort of action to reestablish a sense of safety or agency in the aftermath of the rape. That didn't, and the action, what the particular action was, didn't matter. Some of them, some of them reported to police, but most did not. But they did things like changing the locks on their doors, or moving in with a friend or a family member, or getting a dog, or taking a self-defense class. They did something to re-establish a sense of being in control of their lives. And the other strong predictor was reaching out to other people and talking about it. These were people who told someone, and if they didn't get a sympathetic response initially, they tried again till they got, found someone who could be supportive. The worst recoveries were seen in people who just withdrew and isolated themselves. So no, you don't have to talk with a therapist, but it's a good idea to talk to someone and get support.
Mm-hmm. So,
and by the way, there were about 10% who really made remarkably good recoveries. And these were people who developed what my colleague Robert J. Lifton calls a survivor mission. They made meaning out of their experience by joining with others to try to prevent this from happening again. They said, if I can help one other person or prevent this from happening to one other person, then maybe it won't have been in vain. And so these were people who, volunteered at a rape crisis center, or testified in front of the legislature for better laws, or did public education, or basically said, I never knew this was so common, and now I want to do something to make it a better world. And those people did extremely well.
Thank you. This is very useful and helpful, I'm sure, for a lot of our listeners. So do you think if I'm going through something traumatizing right now at the moment, would it be a good idea to start therapy straight away, or just give myself some time?
Well, I mean, in a crisis situation, therapy can be very helpful, but it has to be focused on crisis intervention. That's not the time when you go into a lot of depth about the background and what happened. It's all very present focused on creating a safety plan right now. What do you need today to make you feel safer? And really focusing on that. So at our Victims of Violence program, we had crisis services, and that, if you were in a being threatened by a domestic partner, for example, an intimate partner, did you need a safe place to stay? Did you need shelter? Did you need food? Did you need to go to court to get a restraining order? I don't know if this is the case in Russia, but one of the big reforms of the women's movement was that if you're being threatened by a partner now, you can go to a judge and they will give a court order that this person has to stay away from you. And so you're not charging him, he's not charged with a crime unless he violates the restraining order, and then he can be arrested.
I wish it worked in Russia, so we just have it on paper. But we do have crisis centers that are making a lot of impact, and I'm very grateful to them. So my question is, you said that sharing about your experience is a good thing. So when you say sharing, can I share it just publicly? Maybe I have a social media account. Do you think if I share about my experience, about my trauma, that that would be beneficial for me? Or do you think it can be potentially harmful?
Totally depends on the community you're sharing with. And so if it is if you feel it's a supportive community where you're not going to get a lot of negative feedback or threats or shaming and blaming, then sure. If it's not a supportive community, or you don't know who's out there, and you don't, then you need to be self-protective. I mean, I think one of the questions we ask people is, if you're sharing your story with somebody, what is the response you want? And they'll say, I want support. I want acknowledgement. I want them to acknowledge what happened and how harmful it was. I want them to believe me and to be, compassionate, and to share my indignation about what was done, and to say that was wrong and you didn't deserve to be treated like that. And then we'll say, but suppose that's not the response you get. Suppose the response is, oh, well, you were always crazy, that, you must have made that up, or who put that idea in your head, or, well, you must have asked for it. And if that's the response you get, how's that going to affect you? And if they say, well, then I'd be devastated, and say, well, maybe this isn't the right person. If you're not sure how this person's going to respond, and you're not prepared for a negative response, then maybe you should think about talking to somebody else. But if they say, and this happens, for example, a lot with family members, where, a child abuse survivor is disclosing to a mother or a sibling, if they say, well, then that's their problem, but I'm not going to keep the family secret anymore. Then we say, go for it, because then you're not giving away your power. You're saying it's going to be a success. It's going to be a success no matter what the other person responds, because you just want to say, this happened to me and I'm not ashamed, and it's not my problem. It's if you don't believe me. So it really, so basically you kind of have to think about, what's the response you want? How likely are you to get it? And can you handle it if you don't get it?
Thank you. So if right now I realize that I would like to work on something traumatizing that happened to me, and I would like to share in a safe community, and I start considering therapy, so which format do you think I should be considering? Is individual format better than group formats? What would you recommend?
I don't think there's a one size fits all. I think the most important thing is to find a good fit with a therapist who knows something about trauma. I think many people will begin with individual therapy and then perhaps move on to group. Uh, uh, and then there are a lot of different and different kinds of groups are really suitable at different stages of recovery. So at the Victims of Violence program, we liked groups a lot. We offered individual therapy, but also lots and lots of groups, short-term groups. 10 to 16 sessions was the usual. And we had one type of group that we called our trauma information group. This was for people in early recovery. And people really bonded more around their symptoms in the present. They didn't go into a lot of detail about what happened in the past, but for example, our first, it was a 10-session group, and we would have a little information sheet that people would take turns reading and discuss, read a paragraph, discuss. Our first information sheet our first topic was, what is post-traumatic stress disorder? And we described the symptoms, and people would say, oh, you had that too? I thought, I didn't realize that was, especially with the dissociative symptoms. People sometimes think, they're frightened of their symptoms. They think if anybody knew about them, they'd say I'm crazy for sure. So explaining the symptoms and how they're a natural reaction to inescapable threat. It helps people make sense out of their symptoms. And then, like, our second topic is safety and self-care is our second topic, because safety has to be the first focus of treatment. And we talk about things like shame and anger and the impact on relationships and so on, trust. And then once people have really stabilized and established safety in the present, our second stage group is a much more exploratory group where people actually do share the details of their stories, and they do this in the service of a current goal. And so it's an empowerment experience that they have. And they also, one of the wonderful things about groups is that people are not only receiving help, but giving it to one another. And they're often much more understanding and compassionate toward one another than they are toward themselves. And so the group kind of challenges people to take in the support of others and, to develop more self-compassion. So, if a group like that is available, I think that's great. But you really mainly, I think, want to look for therapists who know what they're doing when it comes to trauma.
Thank you. And now that you have just said to look for a therapist who knows what they're doing, what do you think are the most common mistakes that therapists are actually doing when working with trauma?
Well, I think there is such a thing as vicarious trauma, vicarious traumatization, when you're bearing witness to the most horrible things that human beings are capable of doing to one another. We can develop nightmares and a sense of our own anxieties and our own grief, and a kind of a secondary traumatic stress picture in which we either become like our patients, either too much avoidance or too much intrusion. And so I think probably the biggest mistake therapists make are avoiding talking about the trauma. Being when I supervise residents still, though I'm retired from the hospital, but I still do supervision there, and they're afraid of trauma. They're afraid of making things worse if they ask too many questions, and so they they don't ask, and then the patients don't get a chance to talk about it. Sometimes therapists will make the other mistake. They will become sort of intrusively over-involved, especially because, especially with patients who have what we call complex trauma, who've been subjected to prolonged and repeated trauma, either in childhood or as adults, where they have been in a relationship of coercive control, of dominance and subordination. And when you've been in that kind of relationship over time, you lose any sense of mutuality, of shared, a relationship in which both parties are have shared goals and shared responsibility and shared benefit, because your only model is you can be a perpetrator, you can be a victim, or you can be a bystander. And if you're a bystander, you can either be colluding with the perpetrator or looking the other way, pretending, you don't see, or you can be a rescuer. And so therapists can get stuck in the position of trying to be a rescuer, say with a patient who's chronically suicidal, or where when I supervise cases, for example, sometimes a therapist will say, I don't usually do this with a patient, but I'll take phone calls at home at midnight, or that sort of thing. And I'll say, look out, because the message you're conveying to the patient is that the patient has no power, you have all the power, and that you can be this superhuman person who, who's going to save their life. When the person who's going to ultimately save their life is them. They, you can't live their life for them. And so, so in that way, I think keeping the frame of therapy where, not only the patient has to trust you, but to some degree, you also have to trust the patient, and kind of explain that you can only, you're not all powerful. You can only do so much, and then the patient has to do his or her part to stay safe.
Thank you, Dr. Herman. There's so much to learn from this. And could you please tell us more about complex trauma and complex PTSD, another important area of your work?
Well, it became clear to me as the more I did this work that the effects of a single impact trauma were not the same as a trauma that was repeated over and over again. Because with a single impact trauma, once it's over, it's over. And presumably you can make it back to some, safe situation where someone is not tyrannizing you. But when you're talking about abused kids or battered women or victims of human trafficking, sex trafficking, or political prisoners, or people in concentration camps, someone is ruling over you every day, and the threat of violence and the threat of violence is present all the time. And under those, and in all of those situations, in order to establish dominance and subordination, the perpetrators use the same methods of coercive control, whether you're talking about torture, whether you're talking about human trafficking, whether you're talking about incest. And violence is the ultimate method, of course, and threat of violence, but there are many others. Control of bodily functions like sleep, eating, what one wears, capricious enforcement of petty rules, and intermittent rewards. Anybody who's studied rat or pigeon psychology knows that a steady schedule of punishment is not nearly as powerful in shaping behavior as punishment with a few rewards scattered in at random. It's the secret of the good cop, bad cop interrogation method. And so, and that makes, you see this with hostages all the time, so that they're not only afraid of being killed, but grateful to be allowed to live, or be grateful to be allowed an extra bite of food. And then the other methods include isolation. That's why political prisoners will do things like go on hunger strikes to be able to receive letters from outside, because their captors will tell them, your friends and family have deserted you, they've informed on you, they don't care about you anymore. Degradation, making people do things that are, disgusting. And then finally, and this is the most powerful of all, forcing people to violate their own moral codes and their own attachments. So, under torture, giving up names of your comrades, or, the oldest kid who, bargains with daddy to say, do it to me, but just don't do it to my little sister. And then at a certain point, he's coming up the stairs and she plays dead and says, hopes he'll go and do it to her sister instead. Or the battered woman who says, just as long as you don't hit the kids, but then by the time he's hitting the kids, she's too terrorized to intervene. So And once you've been subjected to these methods of coercive control, it profoundly affects not just, things like sleep-wake cycle, and you don't just have symptoms of PTSD, but there are profound effects on your identity and your relationships. Basically, you have a contaminated, disgraced identity where people feel they don't deserve to live. And especially if they've betrayed others. And you've lost all sense of mutuality in relationships. Your only template for relationships are dominance and subordination. And so those are it's the identity and relational symptoms that we see in complex PTSD that distinguish it from the more generic, basic PTSD. And fortunately now that concept has been recognized in ICD-11, the World Health Organization's diagnostic manual.
Mm-hmm. Dr. Herman, so now that you said about this identity and relational problems, so what should I, as a therapist, know about the relation of complex trauma to personality disorders?
We back in the 80s, we did a study on exactly that question. My colleague Bessel van der Kolk and I had proposed that we thought that childhood trauma would be strongly associated with borderline personality disorder. We had a colleague, Chris Perry, who was studying people with that diagnosis and near neighbor diagnoses: narcissistic personality disorder, antisocial, schizotypal, and bipolar 2 disorders. And he teamed up with us. He had an enormous amount of information on these subjects, but he had never asked them about childhood trauma. So he allowed us to interview his subjects blind to the diagnosis and to all the information that he had collected about them. And he thought, yeah, you'll find a lot of childhood trauma, but it won't be specific to borderline personality disorder. When he saw the data, the numbers that were coming out of his own data set, he did a complete 180. Over 80% of the borderline subjects had a childhood trauma, childhood abuse history, either physical abuse, sexual abuse, or witnessing domestic violence, or combinations of all the above. And the correlation was highly specific to borderline personality disorder. There was no correlation with schizotypal or narcissistic or bipolar 2. There's a weak correlation with antisocial, mostly physical violence in adolescence. But with the borderline subjects, the childhood abuse began early in childhood, by and large, was more protracted and more, went on for longer, began earlier, went on for longer periods of time. They ended up with more different kinds of abuse, exposure, and so on. So it was a highly specific relationship, and that finding has since been replicated in multiple studies. So from my point of view, it's with people with I don't know about that, 15 to 20% who didn't give a childhood abuse history. My hunch is that I mean, this is just based on a few, individual cases, but one, for example, where there was no abuse in the family, but this was a kid who was born with a heart defect, and she had to have heart surgery as a toddler at a time when they didn't let parents into the intensive care unit. And so this kid was separated from her parents as a toddler, and, in cardiac care unit for weeks. Things like that, where there were attachment disruptions. And to me, it's much preferable to use the complex PTSD formulation, because borderline personality disorders are very stigmatized diagnosis. And if you don't make the connection between the childhood abuse or relational disruptions and the current symptoms, then the patient doesn't help, the patient can't make sense of his or her own symptoms. Whereas once you have the trauma frame, people can make sense to themselves. It's not just if you were born this way, with excessive aggressive drive or something. You're just, but that there's a reason why your relationships are so unstable and why you have so much problem with affect regulation. And once people make sense to themselves, then they can build the skills that they need. There's a wonderful multi-site clinical trial that came out of Germany a few years ago by a researcher named Martin Bohus. And he compared dialectical behavior therapy, DBT, with a PTSD component. So with the skills building first, and then a PTSD trauma processing component with cognitive processing therapy for this population. And the DBT with the PTSD component was superior on every measure. And I think it's because it actually dealt with the trauma.
Thank you. That's really given a lot of thought material. Thank you. And now, unfortunately, we don't have much time left, but I do have one last question for you. And
Sure.
it is about our response as psychologists to the perpetrators. So what do you think about cancel culture? And would you consider it effective in a psychological community? Because for us, this year in Russian psychological community, we had this accident where the president of our trauma association was accused by almost 60 female victims, and he was accused of sexualized violence. And we didn't know what to do. A lot of psychologists started calling for public announcements from their psychological association, but it stirred a lot of debates. So what would be your advice on that for us?
Well, of course, we dealt with the same issues here in the US. Back in the day, in the 1980s, I was the American Psychiatric Association had a committee on women, and I was a member of the committee. And at that time, we were starting to get a lot of complaints from patients about very eminent psychiatrists who were sexually exploiting their patients. And we went to the board of trustees of the Psychiatric Association, and we said, we really need to study this because, you know, this is a real problem. It wasn't just in psychiatry, of course, it was in every field where men at the top feel entitled to, you know, sexual access to any woman they want. Of course, the board of trustees didn't want any part of this. The only person who actually admitted it was a problem was the legal counsel, because they had started to get some lawsuits, and it was costing them some money. So we went outside we raised some money privately, and we did a national random sample survey of psychiatrists, anonymous, so, you know, and we sexual contact with patients. And we found that I think it was about 7% of psychiatrists acknowledged that had sexual contact with one or more patients. It was about something like 10% of the men and 5% of the women. There were very few women psychiatrists, of course, so and all the ones with multiple patients were men. So about 90% of the cases were male psychiatrist with a female patient, then male psychiatrist, a male patient, and then, you know. So, and we actually published our findings. So we, and then we began a sort of educational project within the professional organization about, you know, sexual contact with patients and why that was not okay. And what the impact was on patients for, you know, and started support groups for patients who had been exploited by a health or mental health professional. So there are a lot of avenues that you can use. I mean, we also argued for mandated reporting, so that if we just in the US, if we learn from a patient about child abuse that is going on currently, we are required to report to the state authorities, to the Child Protective Services. And similarly, we thought we should be required to report to the state licensing boards. The patients have, of course, the option to report, and I think now they have the option to report anonymously, in which case the board won't take action, but they will keep it on file so that if they get another report. So this is all by way of saying public exposure is one method of dealing with perpetrators, but there are quite a few others as well, including you know, invoking the state licensing boards to investigate this kind of behavior. And very often patients, you know, they're afraid of retaliation, so they don't want to come forward. But if you offer them enough support, some of them will, in fact, make a report.
So, out of this, I mean, taking into consideration that there is no formal regulation of psychologists in Russia, we don't have licenses. Do you
You
think?
don't have licenses?
No, unfortunately, there is no formal regulation, so it's just us and
What do
our
you mean? Yeah,
institution.
well, then you don't have that option. And I think uh, it may be that public exposure is the only avenue of redress that you have.
So you think
Are patients able to go to court to sue for malpractice?
there are right now more than 60 victims, but they're very reluctant because there was a lot of judgment, even from psychologists, of the
Yeah.
victims, unfortunately.
Well, I mean, that you see, that that comes when you have a powerful group, like a group of professionals that is, you know, abusing their power. The tendency of the bystanders is to cover up, to ally with the perpetrator, because if you ally with the perpetrator, you can and just sort of make this go away. Nothing has to change. But if you ally with the victim, then it's going to be a fight. And most people would rather just kind of keep their heads down, you know, and say it's none of my business. And that's how perpetrators stay in power. They can't do it alone, but it's with the collusion of the bystanders. And unfortunately, you see that pretty much in any organization that has power and wants to keep it.
So, just as a final word, do you think we as psychologists should make it our business in this case?
Oh, yeah. Yeah. No, I think you can offer support for people who have been mistreated by professionals, and we called it cleaning house. We had, you know, psychiatry in the back when I was on the committee on women. Women were maybe 15 to 20% of psychiatrists. I don't know how that plays out in Russia, but you know, it had been a very male-dominated profession, and women, we had just kind of gotten past the, you know, in my medical school class, women were 10%, and you know, we kept our heads down. We tried to be one of the boys, but my theory is that when women get to be about 15 to 20% of whatever organization it is, we clean house. We, you know, it's a dirty job, but someone's got to do it. And so we come with our brooms and our mops and we clean up. And that's happened in the US, for example, in Hollywood. We had the Me Too movement in Hollywood when women got to be about 20% of producers and camera people behind the camera and directors. And similarly in the media, when it's just, when you have a male dominate in the military in the US, we finally, or in the US Senate for that matter, we now have 25% women. And that's when they started to clean up, the gang rape hazing rituals in the military. So that were a deep part of the fraternity structure of the military. So yeah, I think as bystanders, we can either go along to get along and the abuses will continue, or we can try to do something about it. So, but don't do it alone. You've got to have a support group for this, because it is a fight, and it's a long fight. It's not, it's not going to be solved tomorrow.
Thank you so much. That's very inspiring and a lot to reflect on. And yeah, I think on this very inspiring notes, I'll just thank you again on my behalf of my media and whole Russian psychological community. It was such a pleasure to have you here. Thank you so much for coming.
Thank you for having me.